of social and protective networks, loss of income, and decreased access to service worsen their risk for women in India. Women who are displaced, who are migrants or refugees, and those living in conflict affected areas, elderly women, and women with disabilities are vulnerable and affected disproportionately during COVID-19. I'm happy to learn that more than 800 faculty members, non-teaching staff, field practitioners, research scholars, and students are participating in this webinar, representing 25 states, and foreign participants also registered. I feel proud to inaugurate this national webinar on mental health and quality of life of married working women in India, sponsored by National Commission for Women, New Delhi. I congratulate the Department of Social Work for making efforts in materializing this very timely and meaningful webinar. Thank you one and all.
Thank you, Professor Kakri sir, for your encouraging words. I request all the participants to mute your voice as well as video. Please do not share screen. I request all the participants, please do not share screen. It will disturb the presenters. We are going to have 5 sessions by the eminent scholars. Each one of them will speak on the topics connected to the theme of the webinar. I request to kindly write your questions, if any, in the chat box. First session is by Professor Prabha S. Chandra, Madam. She is the professor and head of psychiatry at NIMHANS, Bengaluru, Karnataka. Madam studied at the Lady Hardinge Medical College, New Delhi, and also at NIMHANS, Bengaluru. She has served as an advisor to the WHO and UNAIDS, Secretary of the International Association of Women's Mental Health, a nominated member of the World Psychiatric Association, and an executive member of the Mars International Society. Madam has been NHS International Fellow and consultant in Manchester, UK, and a visiting professor at the University of Liverpool. Her areas of interest are women's mental health, perinatal psychiatry, teaching methods, ethics and elective care. She has more than 180 research publications and has edited several books. Madam has 3 active research grants and has won several recognitions and awards. She has credit of starting the first dedicated psychiatry service, including a mother-baby unit in South Asia for the mothers with severe mental illness. Madam will speak on stress and burden of married working women in the context of COVID-19. Over to Professor Prabha, Madam.
Thank you so much, Dr. Sonar, and all the Dr. Kazi, all the other organizers, and the Vice Chancellor for inviting me for this seminar. And also Dr. Dhanashekaran Pandian, who suggested my name. So I'm extremely grateful, because I think that the people working in departments of social work and associated organizations do such immense work for the people who are vulnerable, and particularly women. So it's my great pleasure to be part of you in this webinar, and thank you for making me the opening batswoman. I think this is a very topical topic for so many reasons. Firstly, we know that mental health in the context of COVID is being considered the second pandemic, and the fact that once COVID leaves, we are going to have a huge mental health upsurge of problems. October 10th is the World Mental Health Day. And so you are just on the eve of the World Mental Health Day. You are talking about something very important because the theme this time of the World Mental Health Day is mental health for all, greater investment, greater access. And I know that all the speakers today will talk about how the mental health of women, particularly those who are married, who are having multiple burden, needs to be invested in, and and women need to have better access. So in that sense, I think it's a great, very opportune time to hold this. So I would share Dr. Sonar's request that if you want to hear me clearly, then you might have to definitely mute your microphones so that I am more clear. And I know it's all very challenging for everybody, but you know, we are all gradually learning, so we are all on the same path. So let me just start with a little bit about the relationship between women and viruses. So it's not new. COVID-19 is not the only virus which is making a difference to women's lives. These are the four major viruses that we've had in our midst in the last decade. Ebola, as we all know, was a huge problem in Africa, and there was a great increase in sexual and gender-based violence, twice as many rapes, and sharp increase in pregnancy rates related to Ebola. We all know about HIV, how women and girls were disproportionately vulnerable, 3 times more likely to be infected than men. Violence or fear of violence was a barrier to seeking testing, and there were increased links between violence and HIV. Then comes Zika virus, which is the most recent, and we know that Zika virus, which was mainly in South America, disproportionately impacted women and girls. And a lot of them had problems because the babies would be born with congenital deformities, and women did not seek healthcare services for fear of being assaulted. And now we have COVID-19 with one of the biggest things with COVID-19 was that domestic violence rates reported doubled post-lockdown, and helpline calls we know increased in all these countries. Also, the National Commission of Women actually set up a separate helpline and a WhatsApp number for women to contact them, and that was really wonderful. So you see, these viruses look so beautiful, but they impact women's life in so many different ways. I think, you know, we all work in the area of helping people, and we all know that stories are very important. And I'm going to tell you stories of 5 women very briefly. These are women who came to us for help through different helplines, meeting us. So we have 50-year-old Supriya. She works as a teacher, and she's struggling with online classes because of lack of tech support. So a lot of teachers who are mainly women have been asked to take online classes by their principals, by their superiors, headmasters, headmistresses. Many women, particularly those who are older, are really struggling with online classes because they do not know them, they find it difficult, and there is a lack of technology support. And one important thing is that everybody's working online in the family. As a result, there is competition for the internet space, for laptops, for phones, and this causes a lot of stress. And invariably, the women are the ones who kind of are so used to sacrificing their needs for others that they end up doing that. And then if she's a teacher, she gets probably backlash from students, from parents, from her headmistress saying, your online classes are not going well. Then we have 33-year-old Meena. I saw as I was looking at the people who have joined in, there was one logo which said nurses bring smiles to people's lives. And I think nurses are one group of married working women who are really struggling in this pandemic. So Meena is very scared of infection because she has elderly parents, but she has to go to work, and she tries to stay away from them, tries to stay in the hospital separately, but that's causing a lot of stress to her. We have 30-year-old Seema. She works in a factory which has closed because of the pandemic. Husband has alcohol use. She's the sole earner. Now, this is the time the eldest son had to be admitted in college. He's passed his 12th standard. She does not have a job. Husband is not giving support. She has to figure out a way of managing finances for her eldest son. So that's causing her stress. Then we have 40-year-old Priya. She's a software engineer, works from home with 2 children, 7 and 13 years old. And you can imagine the differing demands of a 7-year-old and a 13-year-old adolescent. She has to support kids, in-laws, and work very odd hours to meet the client requirements. Of course, she has a husband who's now learning how to wash the dishes, but then she has to, things which she did not have to do earlier because they were fixed hours. Finally, the story of 27-year-old Anita. She's a doctor, she's pregnant, and she was in a dilemma about working versus staying at home because she knows that getting an infection when she's pregnant may cause problems. But now has had to resign her job because her job was not willing to keep her if she was not working, and she has now no paid maternity leave. Now, these 5 stories, if you can see from the various age ranges, various socioeconomic status, various jobs, actually highlight the variety of problems that are influencing women and impacting their mental health. So, as early as September 10th, the LinkedIn Workforce Confidence Index was developed. So the LinkedIn, as we all know LinkedIn, and they developed this workforce confidence surveys every month or so. And what they found was interesting, that even though overall confidence was increasing compared to July among the work professionals, close to 50% women were feeling increased stress. And working mothers are more likely to bear the brunt of distraction from childcare, like the Honorable Vice Chancellor also mentioned. Men are able to seek support from friends and family, but for some reason, women are getting much more stressed. 1 in 5 working mothers relied on a family member or friend to take care of their children, compared to 32% of men. And more than 46% of working mothers report working till late to make up for work. So because they have to manage all kinds of activities at home, they are not able to in the usual times and spend late hours, and 42% are unable to focus on work with their children at home. So these are the challenges that women are facing, and I think a lot of them are having sleep problems, like was mentioned by Dr. Sonar. So Moser in 1993 talked about the triple burden of work for women and COVID-19. So we talk about dual burden often, like we say home, house-related work and office-related work. But I think that with women, there is a triple burden, and I'll take you through what I mean by that. So one, of course, is the productive work, the work that we know. It's associated with paid labor. So we as doctors, lecturers, teachers, nurses, housemaids, garment factory workers. So this is our productive work in which goods are produced and services provided. Then is our reproductive work. A reproductive work is childbearing. And childbearing is, we know how tough that is. Cooking, cleaning, caring for family, including children, the sick or the elderly. Because we know that traditionally, it may not be the norm, but traditionally, majority of the work, not just of childcare, but of looking after the elderly, anybody who's ill in the family, invariably the burden falls on the woman. The third work, which is the community work, focused on improvements to community resources and is often voluntary. So we know that women are actually volunteering to do many other work in the community also, helping a neighbor, helping a distant family member, writing something for their office work, helping students. A lot of the students, actually both men and women, male and female students, for their emotional support go to women teachers and women lecturers rather than going to their male lecturers and male teachers, because women are more empathic. So there's community work, there's house related work, and there's office work. So it's a triple burden which women are facing, and COVID-19 is actually bringing it up even more. The needs of people around us are increasing a lot, and that is actually adding to a lot of stress. Just to give you an example, I have elderly parents whom I've seen for the last 3 months except on video phone, and that really distresses me. But I don't have an option because I have to work in a hospital and I cannot afford to pass on infection to them. This is just a small example of what women are struggling with. This is a very interesting graph for those of you who are in research. And basically, it's not from India; it's from Europe. But it's very, and I think it will be much more, problematic in India. If you look at the red line, that and this is mother's time with child when there is no daycare, okay, and this is father's time with child when there is no daycare or there is daycare. This is mother's childcare activity, and this is the father's childcare activity with daycare or no daycare. The reason why I'm bringing daycare into the picture is that a lot of the mothers managed lives, their work lives better because they had good childcare. So either they left the children with the grandparents, or they left the children in creches, or some kind of daycare. Now, when there is no daycare, the burden of care falls on the mother. So if you just look at this, the amount of time a mother spends with the child when there is no daycare is 502 minutes. The amount of time that father spends is 202 minutes. So father spent half that time. When there is daycare, women spend 368 days. So even when there is daycare, women spend much more time with the children than a father does. Okay? For father, it doesn't make a difference if there is daycare or no daycare, if you can see with these graphs. Whereas for a mother, it makes a huge difference. Let's look at childcare activity. If you look at the childcare activity, a mother spends, even with daycare, about 220 minutes per day in childcare activity, whereas a father spends 100 minutes a day, even with daycare. So what is these graphs showing us? And I think it's very important for us to do a similar study. If any PhD student wants to do this study, it's an area which is very important. Basically, you maintain a diary. The mothers and the parents maintain a diary of how much time they're spending with the child and in child-related activities, and you can actually map over a month how much time is being spent. So this is a very good example of the amount of time that a mother spends with the children, regardless of whether there is childcare, daycare or not. And in the COVID situation, this time increases enormously because the children don't understand when they're at home that parents have to work. For them, mother being at home means mother has to cook special things, mother has to look care of them. And this causes a lot of stress to working women. So what are the pathways and mechanisms to stress and mental health issues in COVID-19? The first one, I think for women and men both, is financial insecurity. But particularly for women, it can be a big issue because if there is financial insecurity, then their autonomy comes down. There is social isolation. And I think for women, we all know that, women work well with friends, they need a group, they need to talk about their issues. Of course, the fact that we now have phones and methods, interaction in the hospital separately, but that's causing still social isolation in women. Relationship conflict, which is close proximity to partner and family. May I request people to mute their microphones, please? Thank you so much. So relationship conflict due to close proximity to partner and family, this is something which is increasing quite a lot. If you go out during the day for about 6 hours, then when you come back, you are able to make do with your family. But constant proximity after the initial 1 or 2 weeks of playing games, watching TV together, all that, after that relationship conflicts emerge and it's becoming escalated. Dr. Sonar talked about domestic violence and family violence. One of the biggest problems is that earlier women were at least able to talk to other women about domestic violence, call up helplines. Now, because they were and people can listen to what they're saying, their inability to disclose family violence. There's uncertainty about the future. Lots of plans have got interrupted for women, particularly having a child. Many of them had planned to have children during this period. They deferred their plans, marriages, relationships. All of that is causing a fair degree of stress and fear related to virus in high-risk professions, particularly nurses, doctors, frontline workers like police women, and other frontline workers who, look after our lives, our public lives. I want to emphasize stress in women health workers, and I was actually looking for data from India. Apparently, the ICMR has actually funded 3 studies which are looking at stress in women health workers. We still don't have the exact data, but roughly about 25 to 30% of women health workers have reports of diagnosable anxiety and depression. I'm talking about diagnosable, not just symptoms. And we all know how the ASHA workers had a lot of stigma related to their work because they were going door to door. We've talked to Anganwadi workers who also had a very bad experience when they were, going door to door and talking to people and checking whether anybody has infection or just fever. High levels of anxiety, especially among pregnant health workers and those with young children or elderly at home. Fear of being a contagion, fear that in some way you're carrying a virus and you can cause infection to others. A new concept which has come called disenfranchised grief. So disenfranchised grief is basically when grief happens and you cannot mourn about it because everybody is going through so much stress and so many problems that your grief is not important. So if a patient dies or if a family member dies, because next day you have to come back to work, if it's a COVID positive person, then that person would not have gone through the whole ritual or funeral rituals. This is called disenfranchised grief of many losses. So a lot of women and men both are going through multiple losses during this. They are not able to grieve adequately. And women are being much more prone to depressive symptoms, tend to take this more in a bit larger way. There is burnout, which is basically depersonalization, that you stop seeing people as humans. A decreased sense of personal accomplishment, that whatever you do, things are not going to get better, and a sense of emotional exhaustion because of all the various things that I mentioned earlier. An interesting finding which has come up in academics, and most of us who are professors or in academics will understand this, that there has been a gender inequity among women academics during this period. So there have been articles in the British Medical Journal, in Nature, in Science, in many social science journals, in economics journals. Why are there gender inequalities in COVID-19 research authorship? And I'm saying this because what happened was that following COVID-19, because there was a lockdown, because people are not going to work and staying at home, there was an increase in number of research papers that people were able to write and proposals that people were able to submit. But what was interesting was that all this increase was more among men academics rather than women academics. And as you can see in this picture, the virus burden seems to be biggest for the women academic who is at the back and is not able to take her burden in front. And they found that there were lesser number of overall research publications and lesser number of COVID-19 related publications in social sciences, in economics, in medicine and science. And we all know what the reasons could be, because women academics, when they were working at home, at least when they were working in their labs or when they were working in departments, they are able to separate their professional lives and personal lives, but they are not able to do so. And many women academics have reported high levels of stress because of this, that they may not get promotions and their male colleagues may actually go ahead. Another big stress is the online world, and women are using internet with greater frequency during the pandemic. It's increased by 50 to 70%, but it has brought its own problems with it. And that is forms of online violence, which are physical threats, sexual harassment online, stalking online, something called Zoom bombing. That is when you're taking a class for somebody or you're doing a Zoom talk, people are able to sending you pornography and things like that, as well as sex trolling. So this is something which is very unique to women's experience in the context of internet. And of course, a lot of women have just said that there's just too many webinars. We are tired of them, and the lack of face-to-face contact with support systems at work and the work routine has hit women a lot, because women would often share problems that are happening at home, at workplace with their colleagues, which they are unable to do now. So the online world brings with it its own issues. I want to just focus a little bit on gender-based violence. I know Jahanara will focus on it quite a bit. But we've recently written a paper, and people who are interested, my email is going to be there in the last slide. I'm happy to share these papers with people. There are some reasons why gender-based violence occurs, and I think it's important for us to talk about it. Poor coping can trigger conflict, arguments, and intimate partner violence. A lot of women are reporting surveillance, that is constantly the husbands checking their phones. Who are you talking to? What are you talking? Unemployment of men is known to actually increase partner violence, and that is something which is happening because of the problem. Interestingly, female unemployment actually decreases the partner violence, but that's not because men feel less threatened. However, if men are also unemployed, that causes problems. WHO, actually, those of who are interested, has recently put out a guidance called Respect, and it's a wonderful document, and it advocates economic strengthening of women and men as a preventive strategy for IPV. So I think governments need to take this into account, and I'm sure the people who are going to talk about advocacy and interventions will discuss this. Women's mental health is directly linked to men's mental health, which means alcohol use or lack of it. Mental health of men is clearly linked with perpetration of violence. So when men have poor mental health, there is perpetration of violence. And somebody mentioned about migration. The Vice Chancellor talked about migration. What used to happen was that male migration meant that men would go out from the homes, but now these men have all come back, and without a job, their violence. I think if we want to improve married women's, working women's mental health, we also must focus on men's mental health. Dr. Sonar mentioned about obstetric and reproductive concerns, and I've discussed some of this. I want to emphasize that there has been a problem with, especially during the lockdown, there was lack of contraception and medical terminations were not available. So there's been a lot of unplanned and unwanted pregnancies. And we've all heard about difficulties during labor. And the fact that COVID-19 may lead to a lot of children who may not really be wanted by the mothers, and hence mothers may have more rates of postpartum depression as well as postpartum PTSD. So I'm about to finish my talk. I just want to highlight, and I'm sure Jahanara will highlight this, but some common early signs of mental health problems, which include poor motivation, being indifferent, restless, lack of energy, problems with sleep, feeling distracted, making statements of self-worthlessness. These are some early signs that you can detect. And I think all of us in families where we see women who are struggling need to be quite alert to some of these signs. Sleep problems are increasing with COVID-19, and studies are looking at it, including sexual problems are increasing. So these are some things that we must be aware about. Another issue which I think is again very important, was raised in the introduction by Dr. Kazi as well, is how help seeking is becoming a problem. So healthcare settings are not open, and especially for a long time, many hospitals are not open. For example, in Bangalore, a hospital like Victoria Hospital, which is where everybody would come for help, continues to be a COVID hospital. So non-COVID conditions are not getting the kind of emphasis that they should. Women themselves are reluctant to visit health facilities because of fear of infections. And there is collateral damage. There's increased burden on health services, so prioritizing COVID-19 related issues rather than non-COVID. Women who had domestic violence would go to one-stop center, shelters. These were not recognized as essential services. Even those who are working are very scared of COVID-19, and we don't have very clear SOPs now which are being formed for how can these centers actually handle it. And if you want to avail of telepsychiatry services, there is lack of privacy. And in fact, the telepsychiatry guidelines don't clearly have, and we're trying to do that. And how do you ask for, domestic violence on tele in a way that is safe for women and does not increase, problems from the abusers? So these are some nuances which COVID-19 is making us think of very remote ways of controlling and managing women's mental health. So finally, a little bit about resilience. I think one of the things that we need to focus on, so while we focus on stress burden, we also focus on balance and recovery, emotional resilience, trying to make our women more resilient. So resilience is of course, is an individual quality of bouncing back after a problem, but the society can also, enable resilience. And how can that happen? So individual resilience is through individual coping skills, your own personal values of optimism, feeling valued in your own role. So I think it's very important for women to learn to value whatever they are doing and not constantly judge themselves negatively. There is interpersonal in families as well as team resilience and the workplace. And because today we are talking about workplace, I think team relationships are very important to constantly check with women how they are doing, with women communicating with each other, providing social support, senior people providing mentoring. I think men also providing mentoring to women and women also providing mentoring to men. So we often talk about he for she concepts, that it's women's problems should not remain only women's problems, but men should actually participate in it, sharing ideas, supervision, what we call Schwartz rounds, that trying to get together at the end of the day to see what else we can do better. And finally, organizational resilience, which is good leadership. And I think the very fact that a university and the National Commission of Women have teamed up to talk about this problem talks about organizational resilience and creating learning opportunities. So looking out for each other, peer support, providing realistic deadlines, especially for women with children, and respecting work-home boundaries. I think now, because there are no boundaries, women say that their employers are very inflexible. They want you to do something late in the evening, early in the morning, on a Sunday, because anyway you're at home. So I think that work from home culture, changing the culture to have clear boundaries, having some online time and support in different departments for support and casual talk. Rather than everything being work related. So everybody brings a cup of tea and snacks and pakoras on a rainy day and actually talks on the online about themselves rather than only work. And of course, organizations themselves providing easy access to psychological support and psychological services. So ensuring women's health in COVID-19 means local, safe mental health support within communities. So the closer this mental health service available, the better it is, because women cannot travel, and so access, like I said, the World Mental Health Day theme for this time: better access, more helplines, and better use of technology, and closing the gender gap in mobile phone ownership, employer support, and governments and organizations to integrate gender in all their policies, including recruitment and promotions. To remember that women during this period were not able to be as productive as men, and to factor that in when you're talking about recruitment and promotions. Paying specific needs for women, adolescents, and elderly. Like I mentioned, mental health of men and family-related interventions, including alcohol-related policies, a strong involvement of women as key stakeholders, and integrate mental health into gender-based violence services. And finally, any COVID-19 prevention materials for healthcare providers has to integrate gender. That has not really happened as much as it should. Some things have happened. The Women and Child Development Department has got something separate for children and pregnant mothers. And we all should act as community gatekeepers to protect women's mental health, and not just depend on the woman to seek help, but we are gatekeepers, and that's our responsibility. So finally, these are my details. People can write to me. I'm on Twitter, and I'm as soon as I finish this talk, I'm going to tweet about this wonderful webinar. I want those who are interested to actually read this freely available South Asia Women's Resilient Index, which examines the role of women in preparing for and recovering from disasters, including pandemics. And I think these are things that we need to make sure that we learn from and prepare ourselves for the next few months or years when these things are going to happen more and more. Thank you once again for this wonderful opportunity.
Now this session is open for discussion. If there are any questions pertaining to presentation of Professor Prabha Madam on the topic of stress and burden of married working women in the context of COVID-19, you may ask the question directly to Madam, and you can also drop your question in the chat box. Dr. Praveen, is there any questions in the chat box? We can read out.
Yes, sir, there is one question.
Yeah, please.
First one question is, which sector, I mean rural or urban, where the harassment cases for women are more in this pandemic to COVID-19, whether place also play an important role?
Thank you very much for that question. I think it's a very important question. Right, like I said, I don't think really we have data available yet. about these differences because surveys are still being done. But I think where personally I feel it's probably equal. I think it's a question of more vulnerability. So poverty by itself is a big risk factor for domestic violence and family violence. And so wherever there is more financial insecurity, food insecurity, rates of violence seem to be high. Protective factors, family support, women being if that is not there, then it is high. So I think more than urban, I think it is the other established risk factors for partner violence, which include poverty, poor social support, alcohol use in partner. I think these three are key, determinants, and they are same whether it's for rural or urban.
Any other questions, Dr. Praveen?
Yes, sir, one more question. How can we encourage teleservices for psychiatric problems to help women in case of domestic violence?
Again, very good question. I think a lot of helplines are now providing domestic violence services. NIMHANS has and I will put it on the chat, we have a dedicated two helplines, one for women who are facing violence and have mental health problems, another for any COVID-related mental health problems. So these two helplines are available. Many of the psychiatrists and psychologists and psychiatric social workers around the country are offering teleservices, and the government of India has actually clearly now made very good guidelines for telepsychiatry services. So these are available as well. We have an exclusive helpline for pregnant and postpartum women who want to have any mental health services, and we get calls many times a day. So I'm happy to provide some of these links on the chat box, and people can access them. Thank you.
Yes, sir.
Praveen? Yeah.
What government is doing for women during this pandemic?
What government is doing for women in the pandemic? Again, I think a very good question. I think the government has tried quite a few things. One, the Women and Child Development Ministry has actually got, if you go to the website, they have a lot of exclusive material for women and for children on their website. And the National Commission of Women has actually started an exclusive WhatsApp number for women facing domestic violence. So that, I think these two things were a very, very important aspect. The NIMHANS mental health helpline, or it's called the psychosocial helpline, actually has 4 options. So if you are an elderly person, you can press 1 number. If you're a child, you can press number 2. And for women, number 4. So even in the helpline, we have a facility where you can actually talk to a woman who will provide mental health support. In addition, in Karnataka, I would like to mention to you that with the government of Karnataka, NIMHANS has actually got a grant where we are trying to understand what the one-stop centers, all of you know what are one-stop centers, where women go for domestic violence counseling. What are the challenges that one-stop centers and women's police stations have faced during the COVID pandemic, and what kind of problems are women coming with, so that we can actually empower them and provide them with more counseling and mental health support. And I'm sure we will all partner in this. So all 30 districts, we, along with the Department of Psychiatric Social Work from NIMHANS, we are actually interviewing the one-stop and counseling centers, and each Anganwadi in each district, we are trying to understand through Anganwadi workers what are the kind of challenges that women have faced during this period, so that we can enable services for them. So these are things which are going on. I'm sure that much more can be done, and I think at the end of this webinar, if all of you can bring in your ideas, I think it's something that we can actually put it down. Dr. Sonar can put it down as a product of the webinar and then present it to the government, so that the government can actually start thinking of doing more than what they're actually doing. Because they also need ideas. And so if we give ideas, they will definitely implement them. So, thank you.
Sir, one more question is there. Hello?
Yeah, you can ask.
Please go ahead.
Vulnerability of getting harassment for women is high in organized sector or in unorganized sector?
So you are saying that so is the risk for women more in the informal or the formal sector? Definitely in the informal sector. I think that is a very important question. Because they don't have the kind of safeguards which a formal structure has. So formal structure will have rules and regulations. They have internal complaints committee. They have strict rules for insurance, etc., and the support system that a department or a formal structure offers. So informal structure, and these are the women who slip through the cracks, and particularly I think housemaids, labor workers. These are the people who are going to suffer the most. And I think the social work departments in various universities should probably start thinking about what can be done for this group. I think there is one more question about what are the suggestions for men in order to make women mentally healthy. As you told that women's mental health is linked to men's mental health. I'm a firm believer that men's mental health is as important as women's mental health. And if we want to feel better, women want to feel better, men's mental health is important. So I think alcohol-related policies are one big key thing, because clearly partner violence is linked to alcohol. Conflict is linked to alcohol use. So that policy is very important. Second, I think men also need to learn to accept when they have a problem, when they are depressed, when they are anxious. Men do not seek help from each other. They do not like to talk about it because they have to be strong all the time. They think they have to be strong all the time. But I think that they need not be strong all the time. They should be able to talk about how they are feeling, about their emotions, share their emotions with their wife also, because then wife will also understand why is this person getting angry. If they do not share emotions, then that's a problem. So I think building support networks for men and providing services for men and telling them, saying you are feeling sad or upset or anxious is not a sign of weakness. Please seek help is actually very important. And finally, of course, men sharing some of the household work and chores and childcare and elderly care. And one thing women want from men is just validate, to just say, yes, I understand how hard you're working. I understand how difficult it is. I can see you're sad. I can see you're upset. Sometimes women just want validation. So I've offered you 5 or 6 things which men can do. So please, I hope that all the men at least in the webinar, will try and do some of these things.
Thank you, ma'am, for your answer.
Yeah, I think many of these questions can be answered by the subsequent speakers, Dr. Sonar, because there's going to be overlap. So maybe we can move on.
Yeah, thank you, madam. Professor Prabha is a very serious practitioner of psychiatry and stalwart in the field of women and mental health. I thank you, madam, for sparing your precious time and sharing highly scientific information and enlightening us. Thank you so much, madam. We'll move to next second session. It is by Dr. Jahanara M. Rajendra, madam. Madam is the head of the Psychiatric Social Work Department at the Institute of Human Behavior and Allied Sciences, Delhi. She was part of a research project, Prevalence and Factors Associated with Medication Compliance in Indian Patients Suffering from Mental Disorders. She has published several articles in the reputed national and international journals. Her areas of interest are struggle of women with mental illness, strength-based approach in psychiatric social work, reintegration of mentally ill persons into community, and stigma among caregivers. Madam will speak on the topic gender and mental health. Over to Dr. Jahanara, madam.
Okay, a very good morning to all of you all. It's a pleasure being amidst all of you all. And first of all, I would like to thank the organizers for inviting me on this important webinar, which is being organized by the National Commission for Women. Incidentally, I'm also a part of on a lot of panels of the National Commission for Women. I'm also on the National Commission for the Protection of Child Rights. Basically, when we have tried and seen whether the children who are living in these institutional care, people who require care and protection, whether they are having mental health problems or not. So we have been on various inspection committees, which has been directed to us by the High Court. that we have to go and check whether the women or young girls who are staying in the homes like Nari Niketan, distress homes, or crisis intervention homes that are being run by the government of Delhi, whether they are housing these people, who may be rescued maybe from the red light areas, or who may be actually, who may be coming to the contact of the police or into the law enforcement agency because, they have run away from homes or whatever. So we have been on a lot of committees in terms of inspection of these homes and seeing whether their mental health and, all other physical and other kinds of health are being actually taken care of. To be very specific, I think we all know what mental health is and what is the, what is the range of mental health services that are being provided, what are the difficulties in terms of mental illness that people are facing. See, all these are very, very important for us to focus now. Though we understand that mental health may be defined as a capacity of individuals and groups to interact with one another and the environment, basically, which allows them to promote subjective well-being and optimal development. If they're in a position to use cognitive and their emotional and relational abilities, if they are very good in all this, then we can say that people have a better mental health. So as we all know, it's just not an absence of mental illness that we are talking about. For people, when we talk about gender and mental health, we are just not talking about anybody who's having a mental illness, but we are also talking about how we need to understand the mental health components of individuals. Okay, can we come back to the first slide, Dr. Sonar, please? Yeah. We all know that mental health is recognized globally. I think all of you are able to read these presentations. It's recognized globally as one of the most important social and public health importance. Okay, and we know carry the burden of this disease, and about 15% of adults in developing societies are also, expected or estimated to suffer from mental illness. The next slide, please. Okay. See, I think
slides are not visible, madam. Slides
are not visible to you.
Yeah, it is not visible to me.
Okay.
Just pin on the slide, sir. Just pin on the slide so that it will be visible for you.
Okay.
Is that it? Are you all able to see it now?
Madam, I can see it. Yeah. It is there.
I know, because even I'm able to see it.
Carry on.
Yeah.
Carry on, madam. Carry on.
Okay, fine. See, we all know that people who are suffering from mental illness and other mental health problems, when we classify these mental illnesses, it may be whether they are the common mental illnesses or the serious mental disorders. Okay, all these kinds of illnesses basically will leave a lot of sour taste in the mouth when people do not have any understanding of why it happens and what is the reason for it and who gets affected most. It leaves a lot of stigma in the minds of, in society, basically. So people who are suffering from mental illnesses, apart from the fact that they themselves are discriminated against, they're not able to seek help because of accessibility issues, for, availability issues of all these factors, because of logistic issues that they're not able to access these, resources, are getting most stigmatized, okay, for the vulnerable population. But I think mental illness, women, as it is, there is stigmatization to this, okay? And see, if you understand mental illness faces a huge amount of difference. Usually, whether the person is having a mental illness, whether it is in, seeking help, from general knowledge, what we can see, if a person, in a man, it gets, sort of ignored because they think, men are supposed to be a little social. Men can be, gregarious. Men can go out and talk a lot. And that means, it gives an impression that the person is happy. At the same time, if these symptoms, hypomanic symptoms are seen in women, what happens is, it is not looked after as something good. A lady is not supposed to be, so gregarious, can't be so social, can't be dressing up and all that. But depressive symptoms in women also is accepted because women are supposed to be homebound. They are supposed to be inside the house. Okay, while if a man develops depressive symptoms, again, it's looked after as, why is it happening? I mean, why are you not going out? मतलब क्या हो गया बेटा तुमको? This kind of an attitude is there with regard to men and women. At the same time, even seeking help for persons who are men and women, it's very, very different. The family members' attitudes, their understanding of why both of them require these kinds of interventions or assessments is not seen very on the same level as it should be. Can we go to the slide now? Can we go to the third slide, maybe, please? There's some problem with the slides. Okay, now let me just talk about some case study, maybe, for us to understand, how women are facing a lot of difficulties in terms of, maybe societal attitudes, family members' attitudes. How are they getting their rights denied, and what kinds of violation these women face? Okay, now we have a case of a 30-year-old man. I'm talking about, all these women who have come to, IBHAS and who have sought treatment here. I'll just narrate a case of a 30-year-old lady who was on treatment for her chronic mental illness. Okay, that was a bipolar affective disorder, and she was suffering from this illness for the last 5 years when she came here. And during this time, she had a broken marriage. She also had a child, and when she had these, with the